Good evening, everyone. We are so excited to launch Breaking the Silence on Black Maternal Health in NELA as a part of the Black Maternal Health Initiative that is nationwide. We are very excited today to host our first panel discussion and documentary viewing. And we have what I consider to be some of the most amazing women in the country as a part of tonight's initial conversation. Um, I have worked with Dr. Jamil Norman to coordinate this effort. We have been discussing this vision for the past year and the passion that we both share for Black maternal health and community advocacy. And I'm so thankful that she really saw a bigger part of this vision and said, let's make it happen. And without her support and collaboration, we would not be here today. So we are so excited to kick this off. And we look forward to sharing meaningful conversations across these platforms over the next few days. We have released a calendar of events that will take place on April the 6th, the 8th, the 12th, and the 17th. And we hope that you all can join us for those events. But we will circle back around to those things. We're going to start the night with an amazing panel on Black maternal health. And I'm so excited that we have some really, really amazing women in the house. First, we have Miss Alexis Young, LCSW, a therapist who has worked in several different realms of the service from schools to hospitals to now in private practice. She has been a guest with me on several platforms and occasions to discuss the power of mental health and advocacy work. We are glad to have her here today. Second, we have Dr. Marla Scott-Kelly, who is an OBGYN. Dr. Marla Scott-Kelly has an amazing background that brought her back to her hometown to continue her work and advocate for those in the DeRidder community. We are so thankful that she is here tonight to share her expertise and that she will be gracing us with her amazing knowledge. Next, we have Dr. Nicole Plenty, OBGYN. She has done some amazing work and does a lot of national and international travel, advocating for the health and wellness of women in the medical field. We are so thankful that she is taken from her time tonight to be with us, and we are very excited to have her as a guest. Last but certainly not least, we have Miss Emma Tate, who is also a nurse practitioner who has done some amazing work in the field of women's health and wellness. She has done work and studies abroad and joins us tonight to be a vital part of the conversation that we will share. At this time, I will step back and start with Miss Young and allow her to continue to share with us just a little bit about what she does and what drives her passion for Black women and Black women's wellness.
So good evening, everyone. My name is Alexis Young. I am a licensed clinical social worker. I've been in the field 20 years and have been in private practice for about 7 of those years, and am currently in private. As I've been in private practice, I've been able to focus on women's health issues, particularly Black women's health issues, with the focus of trauma. It's a love of mine to be able to give back and to be able to address those issues that have not been brought to the table for discussion. And I enjoy the work that I do. I enjoy hearing the stories of Black women and being able to really help them tailor how they can begin to advocate for themselves in different settings.
Excellent,
That's me
Dr.
next.
Kelly.
I'm sorry about
Yes,
that.
yes,
So
that's okay.
I'm Marla Kelly. As Jamie mentioned, I moved back home about 2.5 years ago as my parents are aging. And it's a stark contrast from practicing in metropolitan DC to coming back home to rural Louisiana. I had a lot of change in perspective to look at, but I actually offered quite a bit of change in perspective to not only the people that I treat, but also to the colleagues that I work with. So I have enjoyed that, and I feel like they've actually been aware of a difference and a change. And as we get into the discussion further, we can talk about how we've helped to advocate for not only our rural community, but the Black women in this community. Very excited to be here.
I believe it's me next.
Yes.
So I'm Dr. Nicole Plenty. I'm a double board certified OBGYN and maternal fetal medicine subspecialist, which basically means I take care of the sickest people in pregnancy. So I do a lot of critical care, obstetrics. I treat and manage people with hypertension, diabetes, strokes, heart attacks, COVID, you name it, the complicated stuff in pregnancy. And the reason I went into this field is because I had a cousin that passed away from complications of eclampsia and ended up developing acute respiratory distress syndrome. So that is pretty much why I decided to do maternal fetal medicine. And then I got into more of the advocacy realm when I got pregnant and almost died myself. I could call up my best friend who was my OBGYN. I picked my OB cardiologist. I knew the pulmonologist that diagnosed my pulmonary emboli. I knew the hematologist that anticoagulated me. And I realized that other people don't have that, right? I knew what I needed to do. I knew what I need to order. But if you don't know who to call and you don't know what to say to get things done, you may not know how to advocate for yourself, which can lead to a lot of Black and brown women dying. And so I started doing more public speaking and more advocacy work, trying to help people understand what is important at a prenatal visit, what questions you need to ask, and how exactly you need to advocate for yourself in the most tasteful way, right? Because it's always okay to get a second opinion. But I think people think, well, I just have to stay with this same doctor, or I can't ask too many questions because I'm taking up too much time. When in fact, that is like the complete opposite. So that is why I'm really passionate about this. And that is why anytime anybody asks me to speak about maternal mortality, I'm always going to say yes. So thanks, Jamie and Jamil, for having me.
Hi, everybody. My name is Emmy Tate. It's actually Emmeline, but I go by Emmy, and I am a registered neonatal nurse practitioner, and I practice at Johns Hopkins in Baltimore, Maryland. My history is I have had some experience in both well baby, newborn, labor and delivery, and then found my niche, if you will, in neonatal intensive care unit. And I then transitioned over to transport. So I do transport for Maryland's regional neonatal program, transport program, and transport some of the sickest, smallest babies that Dr. Plenty knows completely all about. So there's that correlation there. I'm an advocate for women of color because I am one, and I have seen the disparities firsthand. So thank you, Jamie, and my sister, Jamil, for having me here.
Well, thank you, ladies. I'm going to give just a little bit on myself, and I'm just so happy to have all of you here with us this evening. I started my career in nursing 24 years ago. I don't know how, because I'm 24 now, but I went into labor and delivery, the only thing I ever wanted to do in nursing. And shortly after, I realized that I loved educating, and I started educating other nurses and was a women's health instructor, and then have advanced up the ladder and associate dean now in a nursing program. But I am a women's health advocate and researcher. And my biggest passion is to make sure everyone is aware of the disparities, right? Because we're never going to fix the issue if there are people who don't even realize that it is an issue. And so I'm just really excited to launch this here, especially in my home state in Northeast Louisiana. I've done research in Texas. I've spoken nationally, but this is really the first time that I've been able to have this platform here in Northeast Louisiana. And I'm just so grateful that Jamie and I have been talking over, it's been a while now that we've been talking about it. And when she was like, let's do it. I was like, okay, great. I was thinking that was going to be next year, but it was like in a couple of weeks. So we did it. We launched it here in 2025. And I hope that this is something that we get to do annually. And we continue to speak about the disparities in Black maternal health until these statistics decrease. So let's just go ahead and get started. And I would like to just ask all of you panelists, what do you believe are the biggest challenges that Black women face in maternal health care?
I would like to say, I think that one of the things for me was finding somebody that looked like me to take care of me. I think that was like one of the biggest challenges that I found. I know that when I was pregnant, I wanted a female, I wanted a Black female, and I wanted either a midwife or a physician to take care of me. And I had a difficult time finding both of those. I did end up finding a female that I worked with, but I did have a hard time finding a Black female at the time to take care of me. So I think that was one of the biggest things for me was identification.
Yeah, definitely. Dr. Plenty.
I think that just access to care in general, like we're all from Louisiana, and yes, we want a Black female doc. Like a lot of people want Black female doctors, but like sometimes you just need a doctor, right? Like just like in DeRitter, there's like no maternal fetal medicine doctors, right? And so if you have, obesity or hypertension, you are automatically high risk, and there's no high risk doctors, and there are barely OBGYNs. And if you try to get an appointment with, an OBGYN, like if you try to get an appointment with Marla, you may be waiting for some time, right? Because she is probably like inundated because people do want a Black doctor, somebody that looks like them. And so just any doctor is a barrier to that. And then when you get into specialty, that's going to be, the real lack of access there. People are traveling to Shreveport to get a detailed ultrasound because they can't get one locally. I mean, that kind of thing is, to me, sad. It shouldn't happen. But that's even bigger than just having somebody that looks like you relate to you. Just access in general to care is hard. And I'm sure as an OBGYN that's in a rural community, it may be hard getting your people, like you have renal disease, let's get you to a nephrologist, like that's comfortable treating someone that's pregnant. That can be a big barrier. So I would definitely say access is huge. And then when you get down to access to people that look and identify and can understand your own barriers is even harder.
Yeah. I think when it comes to people, to individuals who are at a socioeconomic disadvantage, just knowing what you don't know. The fact that you don't know all of the care that you'll need to be able to have a healthy pregnancy is a huge disadvantage. And I think that many of the people that we serve, the individuals that we serve, depending on what type of community, if you're in a rural community, if you work with individuals who are at a socioeconomic disadvantage, which I know I have in the past, individuals don't know the questions to ask. They don't know a lot about their own health history and how that health history can impact their pregnancy. So I think that is a huge disadvantage.
Great. Dr. Scott-Kelly, would you like to join in on the?
Sure will. It's difficult, but someone on the chat actually said being heard. I think that's the biggest thing, and that's Black women or white women. As somebody who was practicing in rural Louisiana, one thing that brought tears to my eyes the very first couple of weeks that I was here was a repeat C-section. This was her fourth or fifth one. I come early to speak to her and her partner, explain to her what was going on, gave her risk, her benefits, There is no alternative to delivery if we've chosen a C-section for you, if this is the fourth one, and went through all of that with her. And she looked at me with a glazed stare, and she was a white woman and she was missing some teeth. That's not uncommon down here. And I said, "Do you have any questions?" And almost with a tear in her eye, she said, "This is my fourth C-section, and this is the first time that someone has told me what they were about to do to me."
Mm.
And I just don't understand that. But in a society, or I should say, in a situation where it has been male dominated, it's I'm the doctor. You're going to do what I tell you you're going to do. There are no other options. And the first thing I say is, this is not communist China. I can't do anything to you that you don't allow me to do to you. You have autonomy in this situation. So I think the biggest thing is being heard. And one more example, I had one patient who we had an angry Black woman. You all know what that is because you've probably been called it once before. And she was a bit angry, and she had a right to be. And finally, my assistant, who is a young white woman, she said, "She's always so angry, Dr. Kelly. I just don't understand. We're really being nice to her." I said, "Get this for a second." I said, "She's had a baby before. It was traumatic. People probably didn't listen to her." And I explained to her situations. I said, "Look at me. I could have been beat up by my husband this morning. You guys wouldn't know it. I don't turn red. I don't blush. You know, I don't turn black and blue. But I have all this internal stuff going on. And the first thing somebody's going to say to me is, she's strong. She's got it. I don't know what's wrong with her." And I looked at my little white assistant and I said, "But if your husband abused you, everybody would know it. And immediately a community would jump around you and console you." Said, "We don't have that because no one notices." So I opened her eyes in that moment, just hearing her, and she changed the entire way that she treated that patient from there until the end of her delivery.
Excellent. Thank you. Thank you, guys. That was good. So let's think about our healthcare system. How does the healthcare system contribute to racial disparities in maternal outcomes?
I think that the example that Dr. Kelly just gave was a perfect example of the issues of the disparities that we see in maternal healthcare because of the biases that people bring in, that healthcare providers bring in, their own personal biases that they apply to situations that they don't even realize they're applying. They do, there are several people that do believe, yes, you are a Black woman. I feel like you're an angry Black woman. I feel like you're going to be a hard time for me. I really don't want to deal with you. And so when a Black woman states, "I'm having pain," or "I am having, these other symptoms, I'm seeing this happen," they're less likely to get adequate care because they are not heard. And that happens time over and time again. And I believe that when it gets down to the wire, when actually someone sees, "Oh my goodness, something is happening," it's almost too late because those signs and symptoms have been ignored. I believe that many times Black women are stating what's happening. They are advocating for themselves, but they are not heard or listened to soon enough.
Right, until it's too late. Just from my own experience in educating students, the misinformation that's even in the literature, that's in their books, that I was appalled at, that I thought, wow, if we continue to teach this, like it was that African American women don't feel pain at the same level of other races. And I thought, if we continue to teach this, and this is what others believe, then how are we ever going to get care providers to understand that everybody's pain is what they say it is, right? And so, I feel that even whenever we're educating, we've got to make sure that we're educating appropriately. Anyone else want to add on that, on our healthcare system?
Well, I think that the system for maternal care it's one that needs to be revamped for sure. I think that because, 80% of maternal deaths actually happen after the delivery, and you have these global fees, if you're pregnant, your OBGYN gets paid basically one fee, right? And then they don't get compensated for the postpartum visit. And so in a lot of systems, that means that if you have a nurse practitioner that's doing a lot of your postpartum care, that's going to go to the nurse practitioner. It's not going to go to the physician that may be more aware of the high risk issues. It's going to go to your nurse practitioner that's used to doing very good prenatal care, but not high risk prenatal care. And so when you have this and you have, the system that sort of almost discourages collaborative care, and in my eyes it does, and that this person has their schedule, you have your schedule, and then you have the nurse that's afraid to tell the doctor, and the doctor that's like, I have my own schedule, that's your schedule, you're supposed to be seeing that patient. It can make people sort of brush things out, right? Somebody comes in, they're completely asymptomatic, their blood pressure is 140/90. Oh, you must have been rushing, so we're going to let you go. That happens so many times, right? It's not until a patient's like very adamant and they come back to like OB triage or the ER that it's like, okay, wait a minute, why did this person get sent home last week with this mild range blood pressure and nobody actually recognized it or saw it? So it is because of how our healthcare system is set up. Something in the documentary that stood out is like, this conception that that patients think that physicians are sort of in this together and it's about a money thing.
Yeah.
It's definitely not a money thing, right? Physicians are not paid what people think we are paid. And if they're not paid, if you're in a system and you're employed and your system is saying you don't see the postpartums because the system is getting paid, right? Your physician gets a flat fee, your system gets a fee, but you're not getting a fee, and your system is saying you're worth more to see this person over here that's still pregnant, or if you're general OBGYN, you should be seeing the GYN patient and not the postpartum OB patient that may have the complication that you could have prevented from continuing to escalate afterwards. So that those kinds of system issues are things that we need to constantly advocate for. Like this global fee shouldn't be global, right? There should be some type of incentive for people seeing people postpartum, or not an incentive. It should be attached to where that person has these sort of check marks that say, if you have these issues, then you have to be seen by a physician. It has to be worked up.
That's good. That's good.
I just wanted to tap into the component of it that's also about cultural competency. Listening to you all also address just a lot of the stereotypes and myths around Black women and understanding the history of the medical system and even the data around the number of Black doctors that are in the profession now. A lot of the work that will have to be dismantled will have to be done by people who consciously speak up about the disinformation. Other than that, the cycles keep going because it's assumed that we only account for a certain statistic in the population, and because the biases of people run deeply. So there has to be a lot of ongoing work to kind of change the history, the dynamics, the textbooks, how we operate on a daily basis, not just in our professions, whatever they may be, but also how those practices and beliefs are inundated into our daily lives. And then we'll start to see it actually create a change in the medical field as well. But what you all say is so true about, even the history of medical practices. Those things are still very present today.
Right.
Yeah.
Great segue to our next question, because of that history and so many believing that that's truly not history, that some of those things are still occurring today in medical practice. How can we improve trust between Black women and healthcare providers? And that, honestly, that's not even just Black women. That is, minorities and healthcare providers, because you'll hear a lot of people say, I'm not going to that doctor. They're going to try to steal my organs, or they're going, all the things that I have definitely heard from patients before, or from friends who don't want to go to a healthcare provider because they're actually afraid, feeling that, they're not going to be taken care of. How can we improve that trust?
Well, I mean, Jamil, I think I would like to speak on that point, that I work at an institution that has a standing history, if you will, of, our reputation, excuse me, of experimenting, if you will, because it's a big research facility at Johns Hopkins, experimenting on Black patients. We know that there has been a history before where invalid children were taken and experimented upon. The parents were told, if you want your child to get this treatment, you have to sign this blanket consent. They had no idea what they were consenting to. They really believed that they were doing the best thing for their child, and that's Black, white, whoever. And then later to find out that, their children were experimented on. Okay. We know that Black women were experimented on for gynecological procedures and not given anesthesia for things, and, told that they don't feel pain the same way, so they don't need the anesthesia. So there's a lot of, history that needs to be addressed, I believe, when you're talking about how to build a trust, is acknowledge that wrongdoing was done. Start from there, acknowledge that there was wrongdoing on their behalf, address it, and work forward from that. The other thing is that we have to, I think, as providers, be better educating, speaking to our patients where they're at, and helping them find the resources that they need to get them the help that they need. So.
And where I am, you have to be excellent at that, because as Nicole pointed out, she grew up here. Jamie did too. We don't have all the resources that we have. So we have to be excellent at making sure those patients get to where they need to go.
Mhm.
There was one thing I wanted to say relating question 2 and question 3. One way that you can improve trust is you can look like you're just trying. So for whatever reason, well, I'm not even going to say that, but also in my clinic, I am the go-to for Spanish speaking patients. My Spanish is decent, okay? If you're a well patient, I can get through an appointment with you. But I'm also not scared to use a verified interpreter on an iPad with a patient. It is no sweat off of me. Yes, it may be a few extra minutes, but it's worth the sacrifice for a patient. I've noticed that my colleagues don't do the same, and I actually had a meeting about that. This is culturally competent care. You must use a validated translation service for our patients who do not speak English. Google Translate is not a validated translation service. And Nicole, you're not surprised. Jamie, you're not surprised when I say when a patient is about to get an epidural, the anesthesia team has a Google Translate. No, 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 no. You need a validated translator. So one of the things Emmy will be aware, since she's in Maryland, I actually practiced with Kaiser Permanente for 13 years prior to coming home. One of the things that is basically written into our work is culturally competent care. It is tied to an incentive payment. So patient satisfaction scores are tied to, honestly, how well you educate a patient, how they feel like they can trust you. I'm going to go and see Dr. Kelly because not only does she speak a little Spanish, she tries, but she's also going to use a Haitian interpreter, a Spanish interpreter, a sign language interpreter. I'm not going to try to scream at you because that makes you understand the language better. You all know what I'm saying. So if you even, everybody's seen it, talking louder doesn't make it better. But
Or adding
when
an O to the end of the word.
exactly. So when you try, patients return to you because they know that you're at least making an attempt. And quite honestly, the truth is, as Nicole said, it's unfortunate, but so much of our time and energy is based on money. If you increase incentive structure for providers who are providing this excellent care that improves quality, we know value equals quality plus access all over cost. If you're doing that and you're providing an incentive, it is so much easier for my colleague here and my colleague here to say, how'd you do that? Why was your bonus more than mine? And it's because I'm meeting these metrics that have been recommended. My patients like me because I listen. My patients like me because I'm going to go ahead and do the pap smear. I actually don't care what you came for. I'm still going to do the pap smear if you need it. So you have to think outside of the box. And I think that's where in a rural community we have actually struggled.
So if I could jump in just really quickly, I know we're being mindful of time. I'm one of those DeRidder natives too, so I understand the disparities that happen in rural areas. And I just wanted to speak from the mental health perspective and how, as mental health professionals, we want to be able to support our provider. And so it's really important for there to be support staff like social workers, like interpreter services, so that we can do the rest of the work, because we know that you're very focused on caring for the patient. And when we receive a referral, we can go in on the back end and get some of that good social information and bring it back to you as the provider, so that we can make sure that the total patient is taken care of, because that's difficult whenever you're trying to wear all the hats. And so I think that's very important to factor in, like, how are we taking care of the total patient, and also being mindful of the provider and how they can do that, as an added note.
Excellent. Thank you. Thank you. You know, I remember when I was a bedside nurse and I was green, I was brand new, and, I was ready to save the world and, deliver all the babies and hold everybody's hand. And there was a nurse that I was working with, and I had a Hispanic patient come in. She was sitting up at the front, and she went and was getting ready to ask her a few questions. And when she heard that she was a Spanish speaking patient, she threw up her hands. She's like, I am not taking care of another Spanish patient. And I couldn't believe what I mean, she was right in front of the patient. And I thought, wow, I wouldn't want anyone taking care of me who is acting like that when I just started to speak. And I just remember going up, and I was still new. And I was like, there's no way I'm going to let this patient feel uncared for, unloved. I mean, and I was like, you know what? Don't worry about it. I'll take this patient. I was, had my patients for the night, and it was okay, because I did not want that patient to have to experience that. And it was, I remember that from, 20 years ago, and there's still so much work that needs to be done.
But
And
Jamil,
so
that's what we do, and it's not fair,
it's
because
not.
as Black women, what we do is carry the load that other people are supposed to carry.
Mhm.
And y'all, in this political climate, that load is heavy. Okay, it is really heavy, and it's taxing, and it ends up being taxing with your own family, your own personal care, your own personal wellness. The truth is, Jamil, I would have done the same thing, and I probably still do the same thing. But our colleagues need to share the load, and there needs to be some sort of punitive something when they don't carry the load. A supervisor should have heard that and demanded that she take culturally competent classes if she had not already.
Perfect segue. How are you guys doing this into our next question on how can medical professionals be better trained to address disparities in Black maternal health? I mean, I feel that at least when I was in school, we were, I think we have changed terminology, but it all comes down to culturally competent care. Really, it's compassion. And sometimes I wonder, can it be taught? What are your thoughts?
I don't think it can be. I don't think that it can be taught. I think that there are people that, well, it can be taught in the sense of that's how you're raised, right? Like, I think that the person's environment and and how they were raised shapes who they are, right? So you have people that have these biases based off of their experience and what they were taught, from springing back to their childhood. Can you put some education on it so that they're aware? Yes, I think that you can increase awareness, and I think that there should be some cultural competency training. And in most major systems, you have that, right? Most major systems have that, and most systems, there's some type of metric that can be attached to that. And when you put a metric which is attached to a bonus, it does make people a little bit more likely to complete the modules, right? Like they will complete the modules, and they will, all of a sudden they'll see a Latina patient and they'll be like, yes, I did it, right? Like I used the Marty and I, express my concern, right? But those are things like the more people do that and the more education they do, I do think that there is some change, some micro changes that happen that eventually looks like real change. But when you have physicians and providers that don't have that mandate, and they are, just in their own little bubble, and they've been excused from the behavior, like the nurse of saying, I don't want to treat the patient because she speaks Spanish, and nobody is, giving any punitive consequences, they're going to keep doing that. So until there's like some mandates that come down, and not just from systems, because everybody doesn't work in a system, but like the insurance companies, the Medicaid, like until it's attached to reimbursement, I'm not sure that that's going to happen at a big level. And unfortunately, our political climate is not incentivizing that at this point. And so it's almost like tearing down anything that's trying to help build cultural competency, which is taking us a couple of steps backwards.
Several steps backwards.
Yeah.
You're right. You're right. For me, I think in my little area, what I try to do is lead by example. So I am bilingual because our parents are Panamanian. And so we are bilingual, and that has been very helpful. And I have recognized and seen the fear, in that mom's eyes when everyone is speaking around her and she has no idea what's going on, but she knows that something bad is happening. And before I go in to move a baby, I always ask the parents, no matter what, do you understand why I'm taking your baby? Because so often on the other end, I hear after we've taken the baby, the mom's called crying, they took my baby. And I was like, well, but you consented. Does she really understand what she's consenting to? Yes, her baby has to go, but does she understand why her baby has to go? And making sure that I'm being that example of compassion when I'm speaking to the mothers and explaining to them why their babies have to go, and let them know that, we'll do whatever we can to get you back with your baby as soon as possible, or get your baby back to you if you can't follow, So I think being the example is one way to do it. But again, it's at such a small level, but I figure something is better than nothing. And so starting small and trying to work up, hopefully having it spread is how I'm approaching it from my end.
Anyone else want to chime in?
I wanted to jump in on that for just a minute, and kind of piggybacking off of what Nicole said as well, Dr. Plenty, I'm sorry, which is about how you kind of break down those systems and practices and how people are reared and what becomes a part of them. Evolving takes inner work, and a person has to have a desire to want to be something different and to want to be something better, and to be willing to study and to be uncomfortable, and in that discomfort seek how to adjust to a different way of thinking, a different way of operating and functioning on a daily basis. And it takes a long period of time. We are not even fully one generation post the Jim Crow era. And there are other micro eras that occurred within there that impact the cultural norms of our country. And so there has to be ongoing work that people are willing to do. And so figuring out how you awaken that desire for people to evolve is one of the greatest challenges. But I think that having a society where it is part of the norm to challenge people to be better, whether it's incentivizing it, like Dr. Plenty talked about, or leading by example, like Nurse Tate talked about. Some kind of way we have to continue, even in this era, to set the tone that the poor treatment of others or the lack of consideration or just not seeking to be better people each day is not something that we will accept. There is a need for people to grow. There is accountability, and there's an expectation for for people to remain uncomfortable until they are willing to grow.
Yeah. So something that I was thinking about, because I feel like all of you are in leadership roles. When I was working in a hospital setting several years ago, one of the docs that I worked with was amazing because she made it a part of psychosocial grand rounds. You know, whatever it was that she said we were going to talk about, that's what we were going to talk about. And I can remember being one of the speakers for one of those psychosocial grand rounds because, you know, what is it that you need to be looking for? Because this does not come natural to many people, and it's not. If it's not incentivized, it's not going to be natural. So, you know, I guess it's a little bit of a challenge. How are you all as providers, which I know you're already doing the work, how do you continue to push the needle? Because we know it's not coming from outside of us because of the climate, the political climate that we're in now. And so even if it's coming from small internal steps, like from us personally, or if you are in a leadership role, how are you saying, we're going to do this and y'all going to show up?
Like that.
Because this is what we
Yeah.
need to do.
Yeah, this is what we need to do. I mean, I am MFM division director at Wellstar Health System in Atlanta, and that's exactly what we say. This is what we need to do. And the good thing about the Atlanta area is there's a lot of Black and brown people in Atlanta. There's not a lot of Black and brown providers, though. Even though we're in Atlanta, it's a lot of us that compared to when I practice in Texas or when I practice in Indiana. But it's still not. We're not the majority. We're still down here in the less than 5%. But because our patients look like me, it's under a microscope that people are paranoid about the healthcare system, and they are almost looking like, what you gonna say? What you gonna say? Okay, you're the Black leader. You are the person that's here at the table. What should we do? Right? And so we say, this is what we need to do. And you say it in the nicest way and say, the way you talk to people is not right. We role play, we bring up examples of, how people have filed complaints and say, well, how could this have been addressed better? People that are flagged as being socially incompetent, we get them, one-on-one peer coaching. Some people have executive coaches to help them with that communication, and that is paid for by the system. So we are very conscious of patient complaints. And I will say, if you're watching this and you don't trust the healthcare system that you're in, or you're not comfortable with the doctor that you're with, it is okay to get a second opinion. It's okay to ask your doctor, what is your care plan for me? And can you break it down for me? And if you feel like you don't connect with that person, it doesn't matter what ethnicity they are, it's okay to get a second opinion. And some people may not identify as much with the African-American woman. They may want to be with an Indian man. I mean, everybody has, the person that can click with you, and that person does not have to be of your same ethnicity to be an amazing provider that can, empathize with you and the things that you're going through in your life. So I would say, keep an open mind. Make sure to get a second opinion if you're not comfortable. And if someone has treated you wrong, send an email and file a complaint, because that if we don't, we're quiet, that the same thing is going to keep happening.
Excellent. Yeah. It all comes down to advocating for yourself, teaching our patients, our family members how to advocate for themselves. My father is getting older, and a lot of times he would just say, this is what my doctor told me. That's, well, what did you ask him? And so now, years ago, it's like, when you go and see your doctor, you should already have all the things that you're talking to me about Even though I love you and I'm your daughter and I'm a nurse, I am not your doctor. So go in there with all of your questions and make him sit down and talk to you, because he would say the doctor just zoomed in here and zoomed out. So he's not going to stay until you ask him something, because you're probably telling him, well, I'm good. Everything's good. And so just teaching our family, our patients, in whatever capacity, when you're interacting with your healthcare provider, that you have to speak up. You have to engage for yourself. And so, we've been talking about the climate, our political climate. And then, even if we take it just down to our institutions and where we work, what changes in healthcare policy or practice do you think would make the most immediate impact?
That's a good question. Immediate. That's an excellent question.
I know. Because, I think there are, when I've done my research before, my biggest thing was I could research statistics and I could go back and charts, but if we lost those patients, it's, maybe it'll work for the next patient. I wanted to talk to women who are pregnant now to see what are the issues? What are you seeing that we might be able to tell what's going on, so we can help mothers not die in pregnancy, help, babies survive, all the things. And, a lot of it came down to like what we've already been discussing about not being heard. But, for us to have big change, real change, we got to make policy and practice changes. And so, when I think about that, I'm like, if there was something, if I could wave my magic wand, as they always say, and I could put something in place immediately that I think would make an impact, what would that be?
So
that wasn't one of the questions, Jamil.
I'm so sorry. I kind of diverted a little bit. I mean, it was a little bit of a question.
I'm teasing because no one's ever asked me that before. Dr. Plenty, you were about to answer, so I'm going to yield the floor to you.
I was, but that is a hard question. I will say, Dr. Kelly, because it's like, dang it, if I had all the money in the world and all the time in the world, what would I do? Having practice in Mississippi, Indiana, Texas, now Georgia's healthcare system is just different. It's different here. I feel like, and the things that I've been advocating for, and I love my job, but they are probably sick of me because I'm very vocal about the changes that do need to be made, specifically to decrease maternal morbidity and mortality. It's not okay to go backwards and then, oh, you have all these complications. Now you go and see the high risk physician. Oh, you have all these complications, but you've never seen your physician at all the whole pregnancy. So our system is a system that has midwives, nurse practitioners, OBGYNs, reproductive endocrinologists, maternal fetal medicine specialists that are the regular part of the healthcare team in terms of prenatal care. The way the system is set up, the first prenatal visit is intake by a nurse midwife. That's the first visit. The second visit is your labs and your ultrasound, also by either the nurse practitioner or the midwife. The third visit is a follow-up visit by either the midwife or the nurse practitioner. And then that midwife or nurse practitioner, if you have a glowing high-risk complication, will refer you to the maternal fetal medicine doctor like me around 20 weeks to get your detailed ultrasound. And then when I'm doing their consult, I'm like, wait a minute, you have a history of gestational diabetes in your first pregnancy. Nobody did early diabetic screening to make sure you didn't have, underlying type 2 diabetes this pregnancy. You have chronic hypertension. Nobody started you on low dose aspirin to help reduce your risk of preeclampsia. Why have we not done all these things? You're on the wrong medicines for your blood pressure. This needs to be switched. So if I had all the things that I wanted, that very first prenatal visit should be done by a person's OBGYN. And then really every visit after that, because that person can lay out the plan, right? Like, hey, you need to be taking these things. And that's the person that's going to be accountable for you anyway, right? That's the person that's getting the global fee for you, the OBGYN. So after that initial high risk versus low risk is established, then they can see their nurse midwife and the nurse practitioner at subsequent visits with touch points with their OBGYN, and then early referral to a high risk specialist if it's needed. That I think could make some immediate changes, at least in the state of Georgia, which has a very high maternal mortality rate.
Dr. Plenty, is there not something in place? Well, obviously there's not.
There's not.
And
I've never seen anything like it. I've never seen anything like it, especially with Black and brown women having 3 times the rate of Caucasian women to die in pregnancy. So we have to become more intentional about this. We have to say, okay, why are Black and brown women dying, right? The number one cause of maternal mortality is hemorrhage, but it's not the number one cause. Well, pregnancy related. It's not the number one cause in Black and brown women. We know that that's hypertension, heart disease, and preeclampsia. Why are they not on the low dose aspirin to help prevent that? Like those are things that can easily be started to reduce the risk of these poor outcomes later on. But if you're not, if your OBGYN doesn't see that until you are, they don't see you until you're 24 weeks and you're not seeing the MFM until 20 weeks. We've almost missed the window.
we have, yeah.
To do that. So that's why I'm like, there has to be some type of system in place. But in Georgia, there are 78 counties that have no OBGYN at all. So then we're talking about the issues with access to care again. It's like a cycle of
That's a vicious cycle.
So,
So I've worked at places where the intake has been done and they address exactly what you're saying, those key things. And after that initial intake, their second visit is with the OBGYN. So that's why I was asking, like, what kind of a system is in place? But you've already spoken to that. So
my mind is going like coordination of care. Whenever you're talking about immediate, like what can most certainly be most immediately done, it sounds like most certainly with you, Dr. Plenty, it's coordination of care. And I think that's across the board though. Like there's not a whole lot of conversation that is going on. And so there are lots of gaps in care. And who is the person that's going to be able to close that gap? And something that I was thinking about, when you have family members who have educational gaps, who are not able to navigate this system. Like you said earlier, Dr. Plenty, I can't remember if we were already live or not. You said, I knew what to do with my own experience. A lot of people do not know what to do. So who is going to be the family member who can be that coordinator of care is where my mind goes. If you don't have it, who is going to be the person that's going to help this person with advocacy? Who is going to be there to say, we need to line all this out. These are the questions that you need to ask, because I think we know what to ask. A lot of the people that we provide services to or provide care for do not know the questions to actually ask. And so that puts them at a disadvantage. Even when they get to see you, it's like, I can see all the things, but they just could not see all of the things before they got to you at 24 weeks.
Yeah. And in our health system, we actually have a fantastic board certified nurse midwife and women's health nurse practitioner who does the intake. And her office is category to mine. And we have a monthly high risk meeting and we go through every single high risk patient. So the 2 OBGYNs, the 2 nurse midwives, the 2 women's health nurse practitioners, we have ACOG guidelines right there. We know the people who are going to see MFM. They do that both virtually and in Lake Charles, they see face to face. So she's fantastic and she's really good at what she does. And because we've afforded her an opportunity to have 45-minute visits, she usually has time to catch everything. So by the time those patients do get to the MDs, her note is the first one I go to look at. And I'm like, oh, okay, boom, she's on this, boom, she's on that, she's on that, she's on that. Those high-risk meetings actually help quite a bit because I'm sure, Dr. Plenty, is that often, and Nurse Tate, is that you get, even in the same health system, sometimes you get people doing it this way. And if you have a BMI over 35, you're doing that. If you have a BMI over 40, you're doing that. United States Preventative Task Force says, just be Black and you need to be on aspirin, because of the chronic stressors that you have. So when everybody's doing something different, so much of it is close to right. Some of it's ACOG, some of it's US Preventative Task Force. When you come together as a system, helping to make everybody at least come close to doing the same thing. We had some people in our practice giving Lovenox to people with a BMI over 35 after C-section. And we decided as a group, y'all know where we live. Everybody has a BMI over 35. But but we decided 40 is the BMI that we're going to use. You get Lovenox after your C-section. So, you know, that's a tough one, and I can see how people get lost. But like you said earlier, I've come across charts where somebody had 142 over 92. Where's the second blood pressure? Where's the
Right.
callback? What happened? You just let them walk out, call them back,
Yeah.
because we need to follow that up. But you're exactly right. It's just being attuned and sharing it as a group and communicating, as Alexis said.
And
I,
also, the burnout, I feel like sometimes because we don't have enough healthcare providers, the burnout will cause some of those inconsistencies, right? Because,
Mhm.
you don't want it to just be another patient, but when you're just trying to get everybody through, it's hard to give that tender, loving care to every single patient every single day, right? And so with that, what can we do as healthcare providers for Black mothers to learn how to advocate for themselves and their children? Because I think it all is going to have, we can't do it all as healthcare providers. We've got to educate our patients. We've got to educate our family. They have to know, what they need to be able to make sure that they are properly taken care of. How do we
Jamil,
equip?
I'm sorry, Jamil.
Yes,
Before they answer that question, can I just throw in two quick comments based
of
on the
course.
last thing you asked? Number one, I just wanted to say that I don't feel that there could have been a better group of women to address tonight's topic than what we chose, because we live in rural Louisiana.
Mhm.
And having doctors that can speak directly to the dynamics of this community, like understanding rural populations so well, was so vital. So I want to first thank you all for how well you are speaking to the challenges that this community faces without living here. The second part, I just wanted to kind of talk about very quickly what Dr. Kelly and Dr. Plenty said, and you all can steer this in the direction for me more clearly. But last year, Louisiana reclassified the misoprostol
Ms. Proster.
as a dangerous controlled substance. So when you started talking about, Dr. Plenty, the necessity of taking that aspirin to help reduce the likelihood of medical complications, these conversations, that's one of the ways that we can, it seems small, but the number of people who will be able to replay this conversation and hear it, for doctors who are not telling them they need to be taking that preventative medicine, or even just to understand how their medical history needs to be addressed, because of this type of change, doctors in Louisiana are a lot more hesitant about how they approach um, women who are having hemorrhaging, high blood pressure history, and other things like that. Dr. Kelly, I know you work with it directly, so perhaps you could speak a little bit more. But I followed that very closely last year, because since Black women are 4 times more likely to die in this state during childbirth, that impacts us disproportionately. So I just wanted to also put the relevance of what you are saying, the timeliness of the conversation. It could not be more important, especially for this state and Northeast Louisiana.
Wow, that's excellent, Jamie. Just a reminder, misoprostol is a medicine that's an off-label use that we use in obstetrics and gynecology all the time. We
Okay.
use it in small doses to induce labor in people who haven't had a cervix that's opened, and we use it in larger doses for people who have had a miscarriage. And we use it for the cervix to open even more so that all the contents of the uterus can come out. Last year, it was reclassified where we actually have to use our DEA numbers to actually prescribe the medicine. A month ago, I prescribed this medicine. I prescribe it all the time because patients have miscarriages. About a month ago, I had a pharmacist call me and say, "Oh, I just wanted to make sure uh, you were using the medicine appropriately." I was livid. First of all, it's 8 o'clock at night and I'm with my family, and you're calling me from a pharmacy. And I said, "Sir, What do you mean? I said, I can't order a medicine without an indication for the medicine. The medicine is for miscarriage or missed abortion, which is also known as. And I said, so why are you asking me what it's for when it's indicated on the prescription what it's for? Oh, no, I just want to make sure, I said, sir, what are you trying to say? I said, it's against the law to perform abortions in Louisiana. Are you saying that you think that's what I'm doing? And I said, please do not ever call me again, because I have patients who are having a loss. That moment they're grieving, and they're getting pushback from a pharmacist who is saying, well, I just want to make sure, call your doctor and make sure that this is what they're supposed to be on. When this is somebody who I've talked to, I've counseled, they know that what they're supposed to do. And another person in the healthcare system challenging my authority with what I've ordered for a patient who is already going through a loss. And that happened since the change of the classification of the medicine. So needless to say, I haven't gotten a call about that anymore, but it goes to show you, for these patients more than anything, you're grieving, and then somebody is questioning what you're using the medicine for when you go to use it. Isn't that awful?
That happens
Absolutely
all the
awful.
time.
Yep.
That happens all the time, unfortunately.
Yeah.
It's absolutely terrible. So, yeah, there's still so much to be done with policy and practice and how we make those changes. But let's let's end on a high note on equipping our women and teaching them how to advocate for themselves. Where do we start? With those who don't know what they should, what they should know, what they should not know, right? Because I've heard it. I've heard it from other medical providers when they're like, oh my goodness, they think they know everything because they read it on WebMD. And yes, I know it does get frustrating when patients don't want to listen to you after you have been educated. But I also am very happy that they're trying to learn for themselves as well. And so, I do direct them to better things, but what can we do? What are the tools that we give them to put in their toolbox to advocate for themselves and for their children and their other family members, right?
You have to look at the person and where they are, what their resources are, right? What is their education level? How can we teach? Because you can give written information to somebody and then find out later that they're illiterate. You can, tell them, yes, log on to this and watch this video. Do they have access to that? So, it's learning our audience, meeting them where they are, providing the resources that are best suited for them, educate the providers who are providing care for them to offer them the appropriate resources. I think it's difficult in some aspects to teach somebody what they need to know to be their best advocate, but we have to start, I think, at the basics. Find out, again, like I said, where they are and meet them there. Find out the best way, do the surveys, ask them how do you best learn? And then, get the resources out to them that best support them that way.
So if you're a patient, right, and you are going to a new doctor, what I always tell people do is, like Nurse Tate said, start with the basics. Like if you don't really write well and you don't, read well, bring somebody with you, right? There's power in numbers. Bring your mom with you to your prenatal appointment. Bring your husband with you. Bring a sister. Bring a friend. Bring somebody with you that can listen also and hear what is being said. Okay. So for my patients who are high risk, like Dr. Kelly's nurse, I have 45 minutes to an hour with a new patient. So I have the privilege of finding all of the things. And then my nurse practitioner usually is seeing people for a follow-up visit if they are high risk, who is amazing, right? And she also has 30 to 45 minutes with them as well. But bring a notebook. Write your questions down before you get there and then write them down afterwards. For me, if I'm explaining something, because I am giving people a whole bunch of risk, a whole bunch of this is the plan, I usually answer questions and then I'll recap. Okay, so what you should have taken away from this conversation is this. These are the points I want to make sure you take away. But if you have a doctor that's not going to give you takeaway points, you make sure you have your own takeaway points. Okay, can I recap what you just said? So what you said was, I'm going to come back at this in 4 weeks and we're going to do this. And you refer me to this person. When do I need to call them, or do you need or will they call me? Ask those questions so you know what are the next steps in your care. And if you're a provider and you're listening to this, one way you can make sure that you are reaching your patient is ask them, what did you understand me say today? What did you take away from this conversation? Especially if you're someone that's giving a whole bunch of bad news, because, some people, any risk to a lot of patients is bad news, right? When it may not be bad, right? I'm talking to people that are diabetics, talking to them about their increased risk of having a baby that's big and increased risk of miscarriage. So that's why we're going to monitor you and all these things. And sometimes all they hear is, oh my God, I have an increased risk of my baby dying. Wait a minute, your baby is normal. Remember, everything is completely normal. We're going to celebrate. This is good. But this is why we're monitoring you. So I always ask people, when I see people get upset, I'm like, what did you hear me say? Tell me what you heard me say? And then I'll say, okay, those are the risks. But remember, nothing's going to happen to you. We're going to make sure that you are safe this pregnancy. That's why we're doing the things that we are doing right now, to make sure that you're safe. So paper and pen, write your questions down before you come. Bring the same notebook, composition notebook, okay? Write it down so that when you go back the next time, you can say, okay, wait a minute. You said X, Y, and Z. Because guess what? Providers are not perfect. And just like Dr. Kelly said, sometimes we go guideline and sometimes we might stray away from those guidelines because of something specific to you. And so you have to be the person that says, wait a minute, what you said this, why are we changing the plan from what you said the last time to now, so that you understand exactly what's going on in your care.
So Dr. Planny, you're correct 100% on that. I like that closed loop. So that is what I tend to do when I'm talking with parents. Like I said, when I go in, I'm like, do you understand why I'm taking your baby? Or they're like, no one's explained, to me why you're even here. So that takes me aback. I'm like, great, you call me, I'm here to take the baby away and you don't even understand why. So, I'll sit down. I remember particularly I had a father who was irate. They called security for him. And I had to go in to talk to him. And I was like, Father God in heaven. I get in there and he's sitting down. He's calm. I sat down with him to get to his level. And I asked him, sir, do you understand what is happening? And he said, no, nobody has explained anything to me. So I sit there and I explained to him. And when I was done, he got up and he shook my hand. He said, thank you. Thank you for just taking the time and explaining to me what is happening with my child. Come to find out it was fear because they'd had a child that was near death, a couple of months before that they'd almost lost. So he was anxious. He was not coping well with it, but this is how it was expressing. He's there to take care of his family, and he felt no control over the situation. Nobody was speaking to him because he was irate. I got him to calm down, explained what was going on to him, and then I asked him, do you understand? What are your questions? Answering those, closing the loop, like you said, calmed him down completely. We were able to take the baby with no issues. They came back, followed us later on. But that communication, like you said, it's just key. Explaining everything. I've given them paper and pencil. Here, write this down. This is what I'm telling you. These are the phone numbers to contact. If you have any questions, write it down, because when we get there and they call you, you can ask them that then. So I think that piece is key. It's key, that closing that loop.
So funny, Amy, when you were telling us that story, I saw Gail King and R. Kelly, and I just see you saying, Robert. You have that calm. You have that calm demeanor where you could you talk a person down, and I could see you just sitting back saying, sir. There's a couple of things. I wrote down 3 things for this question. Number 1, for the women on this call, mentor someone. let's actually prep the next generation. So take a minute to take some young high schooler for coffee who may have shown an interest in you, and you know who they are. They're the little girls at church who come up to you and hug you. They're the people whose mothers are like, can you please mentor my daughter? They're everywhere. So take a moment, whether it's a text message or, sending them something, or um, buying some cocoa for them, or coffee if they're older and in college. The second thing is support our schools. So we all know that Xavier University is opening a school of medicine soon. Yes, yes. And those are going to be our people. And we are going to send those people out. My prayer is that those people stay in the state of Louisiana. The other thing is finally the Edward Via College of Medicine right there in Monroe. It's an osteopathic medicine. So again, when you see people with the DO, they can still practice the same medicine that Dr. Plenty and I practice. They just learn in a bit of a different way. We are embracing those students. We are proctors for those students. We have given scholarships to multiple of those students who will be coming back to Beauregard Memorial Hospital to practice. It would be fabulous if a few more of them were brown. It really would. So when you have an opportunity to maybe precept those students, yes, it's extra work for me. On the days that I have students, I'm there longer. I definitely am, but it's worth the input because I do want to be able to retire myself and know that I've left the health system in good hands because I've helped train the next person to come up. If you think about it, there's always a legacy. There's always an impact. Without Elijah, there would not have been Elisha. Okay. So without Joshua, there wouldn't have been a Gideon and so forth. You have got to plan for your next. And that's the impact that we all want to leave for the next person. So let's just start training up our own replacements. And hopefully that will help us to sleep better at night when we're no longer able to practice.
Dr. Kelly, so what you brought up about Become, I actually had the opportunity to speak for them a few months ago about intergenerational healing and the necessary part that doctors play in that. And of course, when I shared that I was from DeRidder, they brought up Beauregard Parish, and I brought up your name, and they knew who I was talking about. And so we are working on a partnership just for some. When you talk about mentorship, integrating into more community-based things, they'll actually be a part of our in-person event. And so I'm going to reach out to you because we actually talked about DeRidder as well, and
Wonderful.
just how we can continue to kind of build that network of support. So I just wanted to make sure to chime in and share that with you. That Beauregard Parish came up, your name came up. It was an exciting moment. So the impact is felt even locally. It's a small world, very small world.
I
Are you
smell a
feeling
clinical
it in
rotation.
Monroe?
I smell a clinical rotation coming on.
Yeah.
Pretty soon, maybe clinical staff, huh? Okay.
Does Monroe feel the presence of the school though, with it being there?
So that's really kind of how the conversation came up about us working together on some things. I think the community does, but they are definitely seeking to do more. We had an amazing conversation about their ambitions to really just figure out what else they could do in the community. Of course, a lot of the students are not from here, so a part of that is also them feeling comfortable getting their feet wet in the city and learning a new place. So they're very eager, very ambitious, very hungry. I was very honored after I had the chance to talk with them that so many of them came up and said, look, how do we get our feet wet? We know that you work with schools. How can we be a part of it? So I think that they do some great things. We see them, but the students are definitely asking, how can they be visible so that they can do exactly what you're saying? Inspire the next generation of doctors. And then how can they also give back while they are here? So
Dr. Young, do you want to give us our closing comment on advocating?
So I was thinking about, as I was listening to the conversation, as far as advocacy, I was listening to Dr. Plenty, and I was thinking about the importance of that composition notebook, and how that composition notebook from the dollar store, bring that wherever you go, really encouraging our the people that we serve, right, to really bring, like, they can close the gap, right? We're talking about coordination of care and where that gap happens. Many people don't realize that they can be in this process and they can actually say, last time we talked about this, are we still doing this, or has that changed, right? The other thing that I was thinking about as far as advocacy is, of course, me on the other side with mental health. Something was mentioned about anxiety, and how that father was really from Emmy, right? So how anxious that father was because they had just had a traumatic experience with another child. Well, for you as the physicians, you don't have time to go through all of that process, but the referral, right, to a mental health provider so that they can be working on those issues outside of your care can really help your job, right? Because now you can help them where they are in the present moment with what is going on with their baby. And then they can also feel some solace about, I'm going to the doctor, but I don't feel as anxious about it. I don't feel as anxious about the processes. And also they are able to think about the procedures differently. They're not thinking about things as the worst case scenario every time they come in. They're able to have some techniques and strategies to be able to help them through what can be a very difficult time.
Good. That's good. I just remembered, like, when I had my nursing students, I had those brand new nursing students, some fundamentals, and I would teach them how to teach their patients to advocate for themselves with one simple thing. That the first thing I taught them was, when you were doing the med pass, ask your patients if they know what their medications are. Because that's where so many issues can occur. And there are so many patients who have no earthly idea what the nurse is giving them. And I would tell them, I said, you don't ever take a medication from a healthcare provider that you don't know what it is. You make them tell you every single time. And you know your meds. Don't let them draw blood on you and you don't know what they're drawing. Right. And why they're drawing it. And so that would be something I would teach my students to make sure that they were, that was also how it made them learn as well. But that's a really good critical thing that we need to tell our family members.
Yeah,
and
the little
we
white
need
pill
to
is
tell
not
our
going to
patients.
hit it. The pink pill, the white pill,
Yeah,
that
exactly.
pill. Oh my God, sitting here Googling in my office, like high blood pressure medicine that's pink. I mean,
That's pink.
Yeah. And how do these medicate, like, how long have you been on these medications? Because when I see clients and they tell me, because I'm dealing with clients who are primarily like on antidepressants, right, and anxiety meds, like, well, how long have you been on this medication, and what else are you taking with this medication? And they're like, oh, I've been on this medication sometimes like 20 years. When is the last time that this medication has been assessed?
Right.
What medications have you tried already that did not work? So you try to put you on something that you already tried.
Yeah.
Yes.
And so put it all down in the brain, the notebook. That's why I call it the brain. Keep it with you. And so, I think these are just some great beginning things that we can tell women, even about their children. Same thing when you take your child to the pediatrician. What are we doing? What are the vaccines that they're getting? You should know all these things. And so this has just been a fabulous conversation. I think we went a little bit over our time, didn't we? Sorry, Jamie, but it was just so wonderful. We couldn't shut it down. See, and she didn't shut it down either. She said she was going
as long
to.
as they're fine, I was fine, so I'm like, well, okay.
All right. I am going to leave our closing remarks with you, Jamie, and let you take us to our next.
So firstly, I really want to thank you all for such an amazing conversation tonight. It was, of course, excellent and even more than I expected. And just so helpful and insightful. And I know over the next few days, we're going to see a lot of people going in to watch and replay. And so I thank you all so much for sharing such important, relatable, and and resourceful information in a way that the everyday person can understand. Because I think that that's often one of the biggest challenges, is that a lot of times women feel that sometimes the dialogue is bigger than them. And so how do I understand that? And then how do I turn that dialogue into something that I take with me to my next visit? And I think you all did an amazing job today of making it or making this conversation work in a way where people can put it in their notebook and take it with them to the next visit. I also thank you all as well for just having such a passionate heart for the work that you do. My heart is totally full tonight. Just listening to the way that you all are so just committed to your profession for every person that you get the chance to work with. And that's a beautiful thing. So even in just operating as who you are on a day-to-day basis, you're making a tremendous impact on humanity. I will continue to pray for each of you on your journeys. I thank you so much for dedicating your time to us tonight. If Jamil or I can ever return a favor for you, please let us know. We will certainly be willing to do so. Within the next few moments, after everyone has left the room, except for Jamil and I, unless you all want to stay, we will share the screen and begin the viewing of I've Been Waiting, which is part one of the documentary on Black women and medical treatment. I had the honor of being a part of this documentary some years ago, sharing my own birthing experience and just growing up with fibroids and never getting the answers I needed until I was an adult. So there are many wonderful women in this documentary sharing some amazing stories. And in order to encourage people to watch it until the end, I am offering a little incentive. There are going to be 5 questions from the documentary, and we will have about 48 hours to answer those questions. For anyone who answers those questions directly, we will enter your name into a drawing for 2 tickets to the Odes to Black Women celebration that I will be hosting at the end of the month, in celebration of my new book, which celebrates Black women healing and growing and elevates our voices and the truth in our stories. So we really want to encourage people to listen and to engage. So a part of that documentary will be having a chance to win a night of fun and relaxation. So with that being said, thank you so much to our guest. You can stay if you would like, or you can go. And then we will be launching the video in just a few minutes. Thank you all so much for an amazing night. And we will be moving on to part 2.
Thank you.
Thank you.
Thank you. All right, we are now sharing the screen and we will begin our documentary.
So the trust issue again, and going to the doctor and saying, "Hey, I'm hurting," and regardless of the complaint, it always went back to, well, you're weight, or you couldn't possibly be in that much pain.
Is it on? What about my back right there?
Yeah,
Okay.
From the front up.
Okay.
What we're gonna do is we have
That was it. They just started, and I have a big cluster in the top. And I was like, Mama, I said, you don't really even have any gray hair. I was like, how is it that I have so much? She said, baby, you work a lot harder than I do. Yeah, I'm starting to get I got like a Cruella de Vil like road streak right here now. Honey, I would rock that. Okay, what is it? I'm sorry. I'm sorry.
I'm gonna wait.
Hello, my name is Dr. Ramatu Kasimu, founder of Dr. K's Health Minute. I have degrees and background in public health and education. I've been an educator for 9 years. And today I'll be hosting a panel on health and wellness and medical racism with two lovely women and encountering their experiences. Our first panelist is Miss Jamie Mays, and our next panelist is Mrs. Ashley Thompson. All right, ladies, thank you so much for joining us today. I'm gonna go ahead and kick it off if that's all right with y'all. All right. So Viola Davis once said, "You can't be hesitant about who you are." So tell us, who are you?
I feel like every day I'm someone new, thanks to this disease. But I am a wife, a child of God by the grace of God. Um, I am a 7 year lupus survivor, and I am a Dallas native, and I am a Black woman who wakes up every morning uh, to try, even when my body says, "You're not doing it today." So I am a doer. That's who I
I think that's a loaded question for me. Mom, um, child of God, definitely, culture bearer, advocate for those in need, um, fellow teachers, students, and definitely Black women. And I feel that, every day the mission is to just wake up and be my best. So to different people, I'm different things, but most importantly, I just try to be the best person possible.
Okay. Okay. So Zora Neale Hurston, and I'm sure that y'all have heard this quote before, said that if you're silent about your pain, they'll kill you and say you enjoyed it. Studies have documented that healthcare providers exhibit unconscious bias towards members of marginalized groups, which ultimately leads to differences in treatment across multiple domains. Tell us about a time that you lost trust in the medical profession.
I think for me, it would probably be during childbirth. I had spent many years having issues with my female part, so menstrual problems. And when I got ready to have my son, I actually ended up having to have emergency surgery. And my doctor did not tell the medical staff that he had performed surgery on me. And in that moment, I questioned everything. Am I going to be okay to have another child in the future? Did he do this procedure the right way? Um, and I was just very nervous. I didn't even trust my doctor to come back and confidently tell me that I was okay. And I went in to get another doctor's opinion as well. But I also realized that I had to take control, especially as a Black woman. I had to take control of my health. I had to be adamant and I had to be vocal because the only person that was really going to look out for me in the medical field was me.
am. I'm sorry, I'm like tearing up because they had a whole procedure and no one knew. Um, I I think so. I'd always seen the same PCP since I was 8 years old, and so when the lupus suddenly found its way in my life at 23, I went to the same PCP, and he told me, um, "Well, it's a good thing we found it now, because if we found it now, there's no more. There's no more bad news to discover. There's nothing else that um, is waiting." It's not true. um, I was told that I had systemic lupus erythematosus, and that's basically the autoimmune disease that mirrors other diseases, but it lives inside my body. Well, the PCP told me, good thing it's inside the body. We're not worried about it anywhere else. A month later, the rheumatologist called to let me know it was actually on my body too. And then my body would actually start to break out, and I would get a whole new set of skin skins, that I wasn't looking forward to. So I think it was them telling me one thing and the body doing another. So even when I wanted to trust them, my body was telling me not to.
Do you feel like, and this isn't just directed towards you, this is directed towards both of you. In both those instances, you described times where you felt like something was wrong, but your needs weren't being addressed. And so in a sense you were being silenced. So how did you what impact did that have on you? Like physically, mentally, emotionally?
So I began to feel like maybe I was crazy, right? Like phantom feelings, or, I'm feeling something that's not really there. So maybe I feel something in my knee. Maybe it's in my left hand. Maybe it's in my head, and I begin to feel like I'm making it up. And I'm sure, you guys have probably heard, or in your own experience, it's really hard to get a diagnosis and it sticks. Like, you can get one, and then you can get two, and then 87 later, and I wanted one diagnosis for someone to tell me that this is what was wrong. And it didn't come for 13 months.
I think for me, I used to look at like healthcare as a doctor's task, right? I go to them to help me. I do not look at it that way anymore. I look at healthcare as my task. And I go to the doctor to help guide me in regards to what could possibly be wrong. But if there is any insecurity or any doubt I feel, I do not have to accept what one person tells me. I can get multiple opinions. And even more so, I became more adamant about the way I eat, what's in my food, um, just living better each day so that I am giving myself my best shot at a healthy life, because I no longer rely on my doctors to be the source of that.
So what you're saying actually brought up like an excellent point, and kind of leads us into my next question. We do defer to the doctor because we expect them to be the experts. So in your interactions first, did you find that you may have silenced yourself because you expected them to know what they were talking about?
Well, definitely, because I thought they knew what they were talking about, and I assumed that they also knew more than me. But I also had to think to myself, like, who knows more about your body than you do? But I always made the assumption that, well, they know more than I do. They're the trained professional. But eventually, I also had to learn that a lot of it was not even about whether or not a person is trained, but, and this is not to be derogatory, but how much they really care about me. As we continue to look at the studies of medical disparities among Black women, I thought back to my childhood when I had spent years going to the doctor before I became pregnant, and I never got any help then. And I just had to think about how many boxes about the mistreatment of Black women when it comes to medical care. Like, how many things could I relate to? And I could relate to basically every last one of them. So I did, in a sense, silence myself because I felt they knew more than me. But I had to realize that nobody knows my body, what's going on, what's different, what has changed better than I do. And it's not easy because you feel nervous sometimes about approaching the doctors about things that are going on or being adamant about it, especially when people are denying what you're experiencing. But I also learned that I had to continue to advocate for myself until I got to the right person. So I had to learn how to be a big girl and speak up.
But then on the back end of that, it's that much of like medical phenomena, medical knowledge is based off of the exploitation of black and brown bodies, but they still can't treat us. So how, or rather what, are your thoughts on this?
Well, there was a study that came out earlier this week about how the medical field admits that they basically exploited Black folks in particular throughout the years, and even used their studies to develop and push biases and certain laws. I think that this is in part why a lot of people still don't have trust in the medical field. We've been crying out loud about this for a long time, and our voices have not been heard. And in a sense, you feel relief when you hear people admit that we have exploited Black and brown people. But in a sense, I still feel frustrated and angry because we don't have any answers, we don't have any resolutions, and we don't have fair and equal treatment when it comes to medical access. So for me, I still feel frustrated. I still feel aggravated. I still worry because I have a mom that's older and lives with thyroid disease. I don't trust her doctors, and I want to be there. I want her to have me on speakerphone because I don't know that you have the same concern for my Black mom as you would have for somebody white who comes in there to be treated.
That's a very valid point. I think that it causes me to activate, right? So, what can I do, right? Like, what can I eat? How can I sleep better? One of the conditions of my diseases is being in outside in the elements, and so I can't be outside in the UV rays or um, there's a certain amount of sun that I can get, and then it's time to go back inside. That's usually around 20 minutes, and it's time to go back. But how do you avoid the sun, right? So it's caused me to pay more attention to the way that I live, right, and give myself a little bit more time, cut myself some slack, stop trying to squeeze everything in one day, and it really has spilled over into my full lifestyle. I've been able to lose 65 pounds because of paying attention to the different ways. But all of this, and while I want to be like, yes, pat myself on the back, it came out of necessity. I can't trust what you tell me. Let me try to live the best version of myself that I can. That's where we at.
And that is an excellent transition because Alice Walker said the most common way people give up their power is by thinking that they have none. So, research has shown that Black women are the least likely to advocate for themselves in a healthcare setting. What steps did you take to advocate for yourself?
I think for me, it started with number one, trying to see what I could learn on my own. So started looking up ways to have a better diet and how do I deal with, I talked about before, having to have a procedure and having female problems, being diagnosed with fibroids. So what foods do I need to eat to help decrease fibroids? What can I do to help me just manage it before I go into the doctor? Making surgical procedures and things like that the last option instead of my first option, because I always found that if doctors say that frequently, we would take that answer to be it and feel that that's the first thing we have to go with. But looking at that as the last thing, and ways that I can try to advocate for positive health first, and most importantly, asking any tiny question that's on my mind. We tell our students there is no question that's a dumb question. We have to apply that same philosophy to the doctor's office, and stop feeling that we may seem like we don't know much because we're asking these questions. But these are literally, your health is literally life or death. Speak up. That was for me.
That was for us. That was for we. um, wow. Um, she's so right. I feel like it caused me to, like I said before, activate. What could I learn? I'm not in the medical profession, but it is time, to ask as many questions as I can. I was finding that, especially with lupus, there was a lot of tests, procedures I couldn't even pronounce. So we're gonna go ahead and write them out and bring my whole notebook with me to the doctor's office because I can't pronounce this. Let me show you. Can you explain it to me? And that's what we have to do. You can't continue to run procedures on me, stick and poke me for days. Like, because no one has an answer to lupus, there's no cure. You go to the hospital, you might be there a month until they figure out, or they're ready to, send you on to the rheumatologist. So you need to ask questions. Like, even when they get upset, listen, they will come in and tell my husband or tell me, your husband loves you because he's been in this hallway acting up. Good. Somebody is worried about me because sometimes y'all don't.
Mm-hmm.
Did y'all supplement your advocacy with any like alternative practices? While, especially for you, like while they were searching for the answer, were you looking at like alternatives to supplement and to
Um,
try and relieve?
I was. I I started taking an elixir, and so I wake up every morning and I don't know the measurements, but a little bit of apple cider vinegar, a little bit of turmeric, um, and of course turmeric was an anti-inflammatory herb, and so or spice, and so of course I have an autoimmune disease based in everything being inflamed, and so I was hoping that would help. I had heard that apple cider vinegar, this particular one, was with the mother. Not sure what that meant, but you're trying to find right. So you're just trying to find all of these things, that you can do, because imagine sitting there and you don't want to do further harm to a body that already told you is broken. So yeah, maybe not eat fried chicken this night, you know. But that's the truth.
I've definitely tried. Like for me, eating was a big thing. Prior to becoming physically injured, I was into gardening very heavily, growing. And honey, I thought I was doing something. I was like, I'm connected with your ancestors. So, growing my own tomatoes, cucumbers, and herbs and things brought me great pride. But I also felt so much healthier. I could tell the difference in my body. And even though I may not be able to do that same thing at this moment, working with my farmers markets instead of going into the stores where I don't know what's going on. And even if I can't do the same types of exercises, um, even just having maybe a little stretch or something that I know helps me. So I would say overall, just being proactive. Period. If I learned that this is the problem, okay, well, what can I do at home to help me along the way? So I think over time I've tried to adopt a lot of different things, um, to just help me get relief. And but when I started growing some of my own food, I really felt that even mental health wise, it was awesome. But physically, I actually could feel a lot of the difference. And I always try to even share. It wasn't like I was out there growing an acre, just my little thing. But everybody wanted to know what it was like to taste the pickles that were made from your cucumbers. But I realized that it tasted even better than what I was getting out of the store that had all those processed chemicals in it. And I felt more energetic, and even going into the doctor, my blood pressure never even seemed a tiny bit elevated. I was really good with that. So I think that element alone, controlling my food lifestyle, was one of the best things I did to try to take control.
Yeah, I think can I just say
Oh,
something real
yeah.
quick? I wanted to share, and I think it's really important in our community that um, we always look at things from a spiritual aspect too, right? And you mentioned the ancestors, but um, I just feel like as Black people, as Black women, right, we spend a lot of time in the actual doing, right, of having the disease, carrying it, right. Well, I wanted to make sure that I didn't get stuck in the mundane everyday of living it, right. And so I actually, one practice I did was I went to the strongest community I knew, which was my church, right. The Bible says where two or three are gathered, right? And that's where he is too. And so I asked them to carry me. Like, I cannot do this. I'm 23. They're telling me I have a disease. They basically just proclaim death, and there's no answer. Will you help me? Will you pray for me? Will you cry with me? Will you come and sit with me? And that's a practice that for me has been tried and true, right? It's community, it's support, and I'm grateful for. I'm gonna be honest, I don't know Jamie, but I'm sitting here like, thank God for Jamie, because she has a story that she's willing to offer up. I'm sitting here listening to her strength, right? And that's what we offer each other, and that was the greatest practice for me, the practice of community.
Absolutely.
I almost started clapping.
Well, that's a community feature also.
With the insurance of going to different specialists. You know, you retire, and once you retire, your insurance, regardless of what company that you have, you worked for, your insurance is not the same. So having to go from one specialist to another specialist and your copay being $30, $40 to having to go to a specialist and your copay is triple. And now that you're retired, you're on a fixed income. So having to, going from a doctor visit where you normally would pay $30 to now you're having to pay almost $200. And then you're going in and what you're saying is not being heard. You're being told it's this, it's that. And well, I'm going to send you to somebody else. So I think I don't want to say the enslavement mentality, but I think it goes back to, again, a level of trusting, a level of being heard. You know, you can judge the body, but you have to pay attention to what's being said and what's not being said.
When I was pregnant and they first discovered I had the fibroid, and I was just adamant about getting more ultrasounds because I'm like, we don't know what's going on, and I have this random stomach pain, and I have a baby in here. And I remember going to the front desk, and the lady was like, well, typically with the insurance they only give you 2 ultrasounds. I said, well, I need you to check again and see if they'll be willing. Because at this point, it wasn't about me. And I think that's how we are as Black women. Like, we forget about ourselves. But, honey, when it comes to the children,
Right.
or anybody we care about,
Right.
we will go to the limit.
Right.
So I was like, I need you to call and see. And it ended up that I had insurance that didn't have a limit on ultrasounds. And
Run it up.
she could not believe it. She was like, I scheduled an ultrasound, please. And so I got an ultrasound every month.
As you should.
As you should.
As you should.
Yes. And I say it to say it's like, in a sense, I feel like it was the same as how I've had to advocate for myself throughout life. But in a sense, I feel like it was even harder because People don't understand. It's not just how do you get this insurance, it's how do you know to ask me these kind of questions.
Yeah.
How do you know whether this will work or not?
Mhm.
And if you're taking other steps that you start to see results from, you get a crazy look,
Mhm.
as if to question the methods that you have tried, or to
Yeah.
question whether you have the ability to think for yourself.
Yeah.
So it is a lot of the same, but I used to always feel that I was questioned even more in the doctor's office. Especially if there are no nurses that look like me,
Mm.
and there doesn't seem to be any diversity in the office, which we see frequently. I definitely felt that it was harder for me to advocate for myself, than perhaps other places.
And see, you both of you bring up like an excellent point of um, getting that confusion, that pushback of like, how do you even know to ask this question? And again, it circles back to the point that you said earlier of being like, okay, I know you supposed to be the medical expert, but look here, I've been living in this here body for 34 years. I'm the expert on this.
Right.
So
Yes.
then what steps did y'all take to counteract that of being like, I got that you have your medical degree and I appreciate that. That's why I'm here. But at the same time, I need you to hear that when I tell you this ain't right with this, you need to listen.
I think using my classroom skills. Seriously, like I don't have to raise my voice to get my point across. I just need to emphasize that I'm not leaving until we get this addressed.
Okay, yeah.
And that was it. Like, if you haven't answered my question, nothing else really matters. The question is still here, and what I need is an answer. And if you can't provide the answer, I've been with you 2-3 years, and you have gotten X amount of dollars via insurance, then I would go to a place where they are willing to answer me. And being very adamant about that. I think we get so uncomfortable with being stern because Black women are judged so often.
Mm.
But there are certain places where your sternness should not have any flexibility, and your doctor's office is one. And I'm like, you get some healthy dollars for me to come in here for 30 minutes and sit in a waiting room for an hour and a half. Let's get some information here. Let's talk. Let's get this resolved. And not feeling uncomfortable or apologetic about basically demanding that you have fair treatment. Because that's what it is. It's not fair if you can go next door to somebody who doesn't look like me and treat them with the utmost care and sympathy and compassion, and, oh, let us see how this works, and let's try this and try that. If I'm not getting that same type of care and consideration, that is not fair and equal treatment.
I think you're right. I'm gonna be honest. I'm not sticking around for you to mistreat me.
That's it.
I can be treated like trash in the streets. Gotta go. And I'm joking, but I'm serious. I think I wasn't diagnosed yet. It was still in the first year of having lupus or there being an issue, and I went to one doctor because I was hearing often, you better check to see if you can get a disability check. So I'm just being honest. I was, right? And I didn't know. Could you get a check for this? They're giving out checks for sickness. Hold on, let's go see. So I did. And no, one white male doctor let me know very quickly. I'm not approving this. What, you're not gonna go to work? Cause your fingers don't work sometimes? And when I say your fingers don't work sometimes, I actually have Raynaud's, which is a whole symptom of having lupus. If it's too cold, my fingers, my toes, they're hurting. Like, will turn blue. Like, I'm so for real. You ain't never seen a Black person slather up some sunscreen in the winter and the summer. Like, because it's what you have to do. And he was telling me, like, I need to just go to work, pat me on the butt, keep it moving. Wow. So that was my lesson very early on. I'm not sticking around to be mistreated. Bye.
I think that ties directly into what they talk about with how Black women's pain is downplayed. We hear that over and over again. And to say something so insensitive like, oh, just because your fingers don't work sometimes.
Yeah.
Like
It's like
even
that's
even if in
normal.
your mind you
Yeah.
felt that way, to
Yeah.
verbalize that is
Yeah.
so degrading and insensitive.
Yeah.
So how hard is it, and more rather, how important is it to find Black healthcare providers?
Um, I think in the past I've been just very open to someone who cares about me,
Yeah.
but I follow a Black psychiatrist on TikTok, and I follow a Black medical student, and they both talk about medical disparities and the difference in treatments, like what may be a symptom in a Black patient versus what may be a symptom in white patients. And it's been so enlightening. So for me, it has now become one of my first considerations if I think that there's something more serious going on. Just because I realized that there are a lot of differences that a doctor who doesn't look like me may not recognize because they may not put a lot of focus in that area. So in years before, it didn't matter, but I've learned a lot just by following Black medical professionals who point out this is why this happens when you go, and this is what this should look like for you. And I think for me, that's made a difference in how I'm thinking about my medical professionals going forward.
I think as I yeah, I was gonna say as I learned to also navigate the internet, Google is everyone's friend. And imagine just being able to type, I am Black, this is what's happening, and having more answers than the doctor sometimes. And so, to Jamie's point, if I already come prepared, then I'll give anyone a chance. But that's the thing, too. Are they giving me a chance?
What historical traumas have impacted and the health and mental wellness of Black people?
Oh, I think we'll start with the big kahuna slavery. I think that it has been the most traumatic experience because we still struggle with our sense of identity because we don't even know where many of our family members are. And we're not talking about where they in this country. We forget people were snatched from the coast and sent to different places all over the world. So I believe that that is, in fact, the most traumatic impact. And the second one would be the Jim Crow era. Um, there are so many incidents that we don't know about. And the terror that Black people lived through during the Jim Crow period it's just unimaginable what it's like to realize that I don't even need to be in my car after dark. Because if I'm in certain areas, and regardless of what people say, not just down south, sundown towns all over this country, racist communities all over this country, um, I can be targeted and I can be killed. And I think that generationally, that's why it's taking so much work for us to undo a lot of the trauma and a lot of the issues. We see all these ruckus within our families, but a lot of it comes from our people not knowing how to deal with the things we've gone through. Having grandparents that will tell you they were still having to work the fields as children. They were still living under Jim Crow laws, that they couldn't finish school because they had to work the fields to help get enough food to eat. I believe that those two periods alone have caused the most trauma to our community.
And Jamie, can you make a connection? How do you think that trauma has really impacted the mental and health wellness of Black people?
I think the first thing that we talk about is the Superwoman syndrome, right? The idea that even today the Black woman struggles to relieve herself of responsibility. And it's because if we think about our mothers, our grandmothers, my grandmother had 11 kids. And until the day she passed away, she still always wanted to make sure everybody else was okay. She never took a break from worrying about whether everybody else was okay. I think in the way that we raise our children, um, even our ability to sometimes raise them in love and without the aggressiveness, because in a sense, we were groomed by slave masters to conduct ourselves a certain way, and we were beat and whipped, and our kids were beat and whipped. And so we also felt that that was the way we had to train our kids to survive. And it bothers me when I hear people, especially in this era, be very critical of our parents and grandparents. Our parents and grandparents have done the best that they can. It makes me emotional talking about it. And I think we owe a lot to them because we get to live in such freedom and luxury now that they never had. And they are suffering from the trauma they have still had, being ostracized racially, being mistreated, having your voice taken away from you. Realize that had they not gone and had sit-ins and allowed people to pour things on them and said nothing, today you would not have a voice that can speak across countries and the world so freely and say whatever you want to say. But I believe that all of that we are still so broken, and we just need to be freed from the trauma and the pain that hundreds of years we are carrying in that weight still. Hundreds of years of pain that our ancestors went through. And I think it affects everything about us, like our work ethic and even how we see each other. I'll tell people all the time, like, please do not say black folks always unless it's something good coming behind it. Because what I know is black folks always show up when nobody else shows up. I know that black sisters always love you when nobody else will. I know that every bunch has some bad people, but at the end of the day, black folks will bring a stranger into your house and take care of you, and they don't have to know about you and send you on your way. But we have been conditioned to look at our people in a bad way because that is the way they broke us down mentally. And we are still struggling to see the beauty in ourselves, and that is why we cannot see the beauty in our brothers and sisters. And that's a mental health issue.
Part of that is not being the doctor actually paying attention to what you're saying. The regardless of, I'm a considered an overweight person, but regardless of what shape I'm in, what I'm telling you and how I'm telling you I'm feeling should be heard and not what you assume. So when you are not being heard and people or doctors specifically want to assume that they know you that that builds up a wall, because if you're not listening to what I'm saying, how can you ever give me the right diagnosis?
I have one more question for you. What advice would you give to other Black women, other Medias, mothers, and sisters about their interactions with the medical industry and how to advocate for themselves as they go through this process that you have maybe gone through?
Even watching, a good example would be making sure your voice is heard. Don't accept what they're saying. I truly feel that you have a voice for a reason. And if that doctor doesn't want to hear it, find a doctor that will.
My name is Jamie Mays, and the title of this poem is Sun Kissed Goddess. Sun kissed goddess, melanin glistening in the sun. Oh, what a wonder you are. To the eyes that behold your radiant beauty, exquisite you are. Astonished are we, for the intrigue of your powers is inexplicable. Sister, how do you shine so brightly when the light's within? How do you speak to our souls without saying a word? How do you paint the perfect picture without the stroke of a brush? You are magical, sister. Haven't you heard what melanin blessed goddesses do? The way we trade our beauty for someone else's ashes and still end up with beauty every single time. The way we make something out of nothing and nothing out of something, even our imperfections are perfectly created. Sister, how can you heal a man's broken heart with a simple smile? How do you always find the silver lining, even if the cloud is blackish gray? How do you receive the least and still do the most? You are magical, sister. Haven't you heard what melanin blessed sisters do? Ain't no abracadabra to this. No one can voodoo mix this. There's no scientific explanation to this. It's just who we are. It's just what we do. Sister, how are you the strongest woman on earth but never bench pressed or squatted? How do you bring light into a dark room with no windows or light bulbs? How do you raise a nation and only give birth to one child? You are magical, sister. Haven't you heard what melanin blessed goddesses do? We live, we thrive, we give life to everything around us. Black girl, don't you know you have magic? Sun kissed goddess, melanin glistening in the sunlight. Oh, what a wonder you are to the eyes that behold your radiant beauty. Exquisite you are. Intrigued are we, for the enchantment of your power is enigmatic. Sun kissed goddess.
All right. I hope that you all enjoyed that documentary tonight. Um, I've had the chance, of course, to watch it several times, and I've enjoyed it. Not because I'm on it, but just the nature of the project has been very inspiring to me. The work that producer E.J. Johnson did. Typically, his background works with community disparities as it relates to education, teachers. He's even won some awards for the awesome documentaries he's done, and he does a lot around history. So this project was a little bit of a shift for him, but it was an amazing experience to meet these women, and I was really thankful for the opportunity to share my story as well. Um, One thing I want to kind of remind you all is that part one is the opening for what we will continue on Tuesday night at 8. And we had to bump that one back to 8 because I will actually be working. So thank you to everybody for kind of agreeing to make us let us move that one back a little bit later. And then of course we have the walk, the virtual walk on the 12th that we'll give you all more information about. Jamil and I are super excited about that. And then we have the big event in person on the 17th. And we are super excited about that night. We'll be viewing the documentary, or part two of that documentary, in person, opening up the floor for questions and story sharing. And we have some amazing panelists slated for that night as well. And I don't know, we may have some other goodies coming along. We've been getting a lot of follow-up from people as well who are interested, and we're very thankful for that. So please stay tuned. Watch Jamil's timeline and my timeline. Please follow the Black Maternal Health page if you have not followed it yet. We just started that up. So thank you to everyone who has followed it. And then most importantly, and then I'll turn the mic over to Jamil, Remember that I did share 5 questions today from the documentary. If you answer those 5 questions, you will have your name entered to win 2 tickets to Odes to Black Women, which is my book release celebration that is coming up at the end of the month, which I'm very, very excited about. Those questions come directly from the documentary. So we will drop the link if you want to go back and watch the documentary directly to watch it. But whoever answers by Tuesday night, we will do the drawing and announce the person who wins those tickets. So thank you all so much for everything you've done, for tuning in tonight, for all the shares, the questions, the comments, and the love you've been showing. I'm going to turn that mic over to Jamil and let her finish up.
I just wanted to say thank you as well. Tonight was just amazing. My cup is full. This is definitely my passion. It was just so great to actually talk about Black maternal health, but really bring it into Northeast Louisiana. And I'm excited to see where this will go. And I'm really interested in doing some research here in Northeast Louisiana. The research that I've done in the past has been in Texas, and some counties in Texas that have high mortality, Black maternal mortality rates. And so, we're in that poor statistic as well. And so I really want to use this as a launching pad to be able to talk to more Black women here in Northeast Louisiana. So thank you so much for those of you who came out tonight and tuned in tonight. And I look forward to seeing you again on Tuesday as we continue the conversation. Want to see all you guys walking virtually and sharing your links and hashtags with us for the walk on Saturday, and then our live event as well next week, Thursday. I'm very, very excited about our live event as well. So hopefully we'll be seeing you guys again. All right.
Excuse me. You all have a good night and thank
Good
you.
night. Bye.